Got it. All right. Yeah, we'll give it a couple of minutes just as people transition out of clinic or other activities. Our custom has been to start around 12:17, which is fitting on the 17th. Hopefully everyone is doing well and ready for the holidays, whatever that may look like for you. Folks. Kristen and Deborah, welcome. Sylvia and Christine and Kara, welcome to you also. Let's give it another 30 seconds or so here. Get started. All right, looks like it's 12:17. Well, again, welcome. I'm going to go ahead and share my screen and see. Looks like Kathy Jacoby is also joining, which is great. All right. Welcome to our November session. Only doing one session this month and next out of respect for time and holidays and schedules. Our format will be the same as always. Some quick opening notes and reminders. We will, looks like everybody who is here is well known to us already, so maybe we'll skip introductions for the sake of having time to talk about Lynne Korte's fantastic didactic covering our updated 5-year update for our Washington State Plan to address Alzheimer's and other dementias. And then much gratitude for Julie Holgado coming back to continue the discussion of the case that we talked about last time. It felt like there was much more to talk about there. All right, so Zoom reminders. I think we're all skilled in this at this point. So it looks like also everybody is named appropriately. It's muted, but if you can have your video on, that's great. If you can't, understand that too. And if there's anybody else in the room with you, go ahead and put their name into the chat so we can keep track for CME and other purposes. Speaking of CME, there's some reminders about the UW Traumatic Brain Injury Behavioral Health Echo, the Addictions Echo, and the Telebehavioral Health Training Series, and some of the other consultation and conference series options. These are always in our slide decks, so this contact information is there. Just a general reminder about protecting PHI. We have done our best to remove any of that and also do our best during the conversation not to reveal any information that may be sensitive. We always appreciate your surveys, and we have one more session, 2023, our own Dr. Nancy Eisenberg, who will be talking about women's brain health. We are very close to being done with the first probably 6 months of didactics for next year, and we'll announce that at our December session. Boy, cases, we love them. They are so important, and I've always appreciated, and I've learned a ton from everyone that we have discussed. So if you or anyone you know would like to present a case, Samantha is your person, and there's her contact information. Accreditations, we are accredited for CME, 1.25 credits per session. We have no disclosures, including our speaker or any of the planning committee. Here's our fantastic hub team. Here are your fantastic locations. And here is the utterly fantastic Lynne Korte, who will be doing our didactic today. I'm going to stop sharing that. And Lynne, I'm happy to turn it over to you, and either Samantha or I can draw the slides.
Well, and thank you for that fantastic introduction. So, those of you who know me, I work at Aging and Long-Term Support Administration, and I'm Dementia Care Program Policy Analyst, so most of my work actually happens with external partners. So I have traditionally worked on behalf of our agency and trying to increase dementia capability there. But over the last probably 5-6 years, I've transitioned to working mostly with external partnerships, including developing and implementing the Washington State Plan and supporting and managing the Dementia Action Collaborative. So if we go to the next slide, I just do want to just acknowledge what we have been doing over the last year. It's actually a year and a half, because really this was a huge body of work. And when we were tasked with this legislation to update the state plan, one of the first things we did was want to go back and look at what we have done. And, you know, in doing that, I just want to acknowledge the many, many people. We had over 60 people that were working with our Dementia Action Collaborative at the time who helped in both implementing and now updating the plan over this last year and a half. And some of those overlap with this group. So just a big thanks to Chris Rhodes, who chairs the Health Medical Committee and also sits on our steering team for the Dementia Action Collaborative, Nancy Eisenberg, Kristen Childress, Barack Gaster, Carolyn Percy, Carrie Rubenstein, and Kathy Jacoby, who's on the line. So all you folks have just been integral to this work. And, you know, none of this could really happen without people like you who are willing to take a step away from your clinical work and step into some of this process work of how do we actually improve things across the state. So just a huge thank you to all of you who've been involved. And, you know, without your voices, we really could not do this. So thank you all for your time. So this process, as we had looked back at what we had done, we sort of took a careful look at what had we done, what had we not been able to accomplish, but we were also looking at what new knowledge or advances in research had occurred since the time that we developed our first plan, and looked at sort of the current landscape of healthcare and long-term care, both nationally and here in Washington, and sort of what had changed. So throughout the, the plan development, this update, we had really pulled on the expertise of this group, and also engaged over 2,000 public voices from throughout Washington, both within a consumer survey and listening sessions. So this work and this outreach really helped the DAC to sort of come up with some priorities. What do we really need to be doing over the next 5 years or so? And that's what culminated in this state plan. So in a state plan, you know, our group originally, when the first plan was published, just didn't want this to be a plan that was going to sit on the shelf. We want it to be a call to action. And one of the calls to action is for state agencies to collaborate with each other and to collaborate with all of our partners out there in the state on dementia-related concerns that can really benefit from a coordinated approach. So, you know, some of the things that sort of jumped to the top as we were talking are, you know, reducing potentially modifiable risk factors, reducing preventable hospitalizations, developing a multi-sector plan for aging, and working also on health disparities and equity related to dementia. So those were some of the things that just kept popping up that we need to work on sort of on a cross-sector basis. So if we go to the next slide, I just want to sort of highlight a few of the things that I think were new in this plan after we had done all that research and started working forward. You know, it was after the Lancet was published, after we published this plan, the Lancet had come out with all, you know, their work, I think that was 2017 or so, on the potentially modifiable risk factors. And then that was updated again in 2020. So there's really been now sort of a much stronger evidence base that can provide an impetus and a platform to take actions towards better brain health and reducing risks related to dementia. So this includes evidence around the link between brain health and heart health and thinking about that across the lifespan. So you'll see things in this plan about increasing awareness among the public about those issues, and increased action in healthcare, such as promoting sort of heightened attention to managing chronic conditions such as hypertension and diabetes across the lifespan. And you'll also, we've also seen more evidence in recent years on just overall healthy aging and its impact on brain health. So this plan sort of really promotes this idea of increasing awareness about and paying attention to the healthy diet, staying socially active, exercising both the mind and the body, avoiding tobacco, and avoiding excess alcohol. And I know to the people here in this room, this is sort of preaching to the choir, but these are messages that we want to get beyond us and out into the general public and into sort of the realms, beyond us. There's also been an increased awareness and a stronger evidence base around social determinants of health and how they affect health outcomes and risks. So this includes delays in detection and treatment among racial and ethnic groups. We did a dive into Medicare data when we were doing this plan. And in our data, we could see that the prevalence of dementia is higher for Blacks and African Americans and for American Indian Alaskan Natives compared to non-Hispanic whites. There was a slight differential in this data set for the Hispanic Latino population, but not as great as national sort of studies would indicate. So this plan really is continuing to promote the life course approach because we had started with that idea, but I think now we have some more evidence even towards the importance of that. And we want to be able to leverage public health, public awareness, and healthcare to incorporate some of the important things that we found and put some actions into practice. So during the original plan time, we have developed some new resources and tools, but we just have this continued challenge to get them out and about, sort of beyond this group into the broader community and out into healthcare professionals that are not involved as you all are. So lastly, we made a big effort in this new plan to try to really engage partners beyond us. So we made an effort, and I'll explain this a little more as I go on, to try to engage people and have themselves see themselves in the plan. So some things that we did, we outlined a special appendix called Appendix C, and it's called Suggested Actions for Community Partners, where we were very specific about, here are some simple steps you can take to align with the goals of our plan. And so I'll bring that to your attention as we walk through this. So next slide, please. We didn't change our goals. We did a little bit of refining. So these are not new goals, but we did a little bit of refining in language to reflect some of those things I just talked about. Really, it is big and broad, right? It's a lot to do. So really the idea and hope in this is that we can all work together across these both public and private sectors and collaborate across systems, across public health, healthcare, and long-term care to keep our messaging and actions aligned so that when we develop some messages in brain health to use in healthcare, we're using similar language that is aligned, that we're getting it out to public health and long-term care, all in the same sort of tone and messaging so that we're really consistent. And by doing that, we can really amplify some of the progress that we can make by aligning those systems. So in the next slide, if we move to that, you guys have seen these resources, but I just want to, there's some of these resources I think that sort of fall off our radar. And, we really want to bring them top of mind to people. Now, I want you to think about this, not so much as informing you because you guys know about this, but as we walk through this, think about who do I know in our partner network that might not know about these? So be thinking about that a little bit, because most surveys, when we ask our consumers, who do you turn to for information and support? It's you, it's healthcare providers. They're turning to you for advice, for guidance. This cohort of older adults really trusts healthcare providers to be providing them with the latest information. So one of our strategies has been to support healthcare as much as possible. So to be putting these tools and resources in your hands. So not only tools for you, but things that could be shared with family. Now we're using a lot of other methods to try to get them out to the public and to families, but just trying to make sure that you all know what's out there. So, you can share them as appropriate. So if we move to the next slide, I'm not going to spend a lot of time on these, but again, to bring them top of mind, we had started with this clinical provider practice tool. This needs to be updated, I think, take a look at it, but it's a great start for somebody who's new into this, the screening and diagnostic process and some of the basic resources and considerations sort of at that beginning stage. For providers who aren't familiar, then they're just starting to come aboard. I think this is still a useful tool. And then a couple of years ago, I was trying to remember, Nancy, when we did this, because you were integral to this. I think it was 2 years ago we started working on it. And this is sort of the beyond diagnosis clinical tool. So it went into after the diagnosis, and you're starting to go through the early and then mid stages. what are the resources, what are some of the steps clinicians could and should be taking, and how can we, be working with families along that pathway. And then we also developed a healthcare provider educations matrix where we identified a whole bunch of online and other resources for healthcare providers. If there are people in your networks who need more education, it just provides, here's some information where you can get some training. And then we developed an action brief for hospitals. And this is on care transitions. So recognizing that we do have preventable hospitalizations that are happening and readmissions that are happening. So this is sort of a fact sheet that outlines for hospitals, here's some best practices, some simple things you could do now, low-hanging fruit, and then here are some models you could consider to prevent readmissions for people living with dementia. And all of these things, just that I'm mentioning, you could find them at our Dementia Action Collaborative page, which we'll put into the link as we go. So next slide, and then you could just go to the next one. These are tools I want to focus on for families. And I do want to acknowledge that as we have gone along the pathway, even from the beginning, what we're talking about are two key referrals to resources for individuals with dementia or their families. And those two key resources would be the Alzheimer's Association and then area agencies on aging. And I know that you guys have had full sessions in what the Alzheimer's Association provides. So I'm not going to go into depth, but I do want to remind you that, if you're at a loss for how to help some families, these two referrals are really getting them to sort of the key people who could help them, I think, with some of the needs that they have. And, the Alzheimer's Association, I do want to point out, people always underestimate the value of, support groups. And I know with the pandemic, some of those went by the wayside, but some sort of virtual ones popped up. It just never ceases to amaze me how much you can get from a support group. And I know some people resist going to them, but some people might be more amenable to some of the online ones that are happening now. But I just feel like there's such a great resources for families to learn tips on a whole variety of things. So just, remembering that and remembering this 24/7 helpline, because I think that is just something for families to hang on to where they could get some support. But I want to talk a little bit more about AAAs because I think area agencies on aging, because they go by different names and they have different assets and resources in their community. So it gets sort of confusing. And so I just want to provide a little bit of information about that. All of our area agencies are required because they get Federal Older Americans Act funding to do certain key things. And those key things are up on the screen. They all have information and assistance. They all have family caregiver supports. They all have links to financial assistance programs, and this is not just Medicaid. So if you guys are thinking it's not just Medicaid people have to be eligible for, but we have sort of what we call pre-Medicaid. We have what's called a Medicaid alternative care program, tailored services for older adults that are for people who are above the poverty level, say within 400% of the poverty level, where we can provide some assistance for them to help stay at home. But we can provide referral to other sorts of resources that are helpful, that aren't necessarily Medicaid, but services that can really be helpful. What I want you to do is to think about, if you're not familiar with who your area agency is and you're not comfortable with what they provide, to take a look at some of their websites. If you can't find them, I can help you with that. But even if you're ever unclear on whether they're eligible for certain services, it's helpful to refer people to their local AAA and or a family caregiver to the Family Caregiver Support Program, because they have lots of different ways, even sort of, they're not things that are like big eligibility, but ways to help families with tips and guidance. So just keep that in mind. And I want to provide an easier way for you guys to get at some support for families. So if we move to the next slide, what I want to share is that while AAAs might have their own different names, they are bound together by this common branding called Community Living Connections. So we would refer statewide to AAAs as Community Living Connections. And there is a Community Living Connections webpage, which is it's sort of managed by Aging and Long-Term Support Administration, but it is fed into by different area agencies on aging. They put their resources into this sort of resource clearinghouse. So it has some general information about programs and services and the opportunity for families to click on a county and find very specific county information. And we also have this dementia specific page where if people click on Alzheimer's sort of in one of these sections, they get to sort of dementia specific resources where we have put our DAC resources. But before we leave this slide, and I'm going to ask you to switch in a moment, but do you see this arrow here, this sort of yellow arrow? And it's pointing to this button called Connecting to Local Services, Connect to Local Services. So if we go to the next slide, when you click on that Connect to Local Services, this is assuming, of course, first you've gone to waclc.org, because that's the Community Living Connections website. If you were to click on that Connect to Local Services, you're going to get to the next screen. I'll show you in a moment. And you get to this little button that says Refer a Patient, and that's in the upper right-hand corner. And what that's going to do is get your information about your patient, your specific patient, to the correct AAA, where you can provide some information, and then that AAA staff will provide the information directly. So if you go to the next slide, what you'll see is that this is a HIPAA compliant form. So you could put in your client's information, and then, so you don't have to bother with, oh, who is the right AAA? You just put in the information, it'll go to the right person. So below this little button that you'd see on the screen, here is a direct link to that. So if you wanted to bookmark that, or we put this little QR code that gets you to the HIPAA compliant form. So once you get to that form, you're going to fill out the information about the person, and then you have this opportunity, if you see all these needs off to the right, like if the person is having a lot of falls, we have falls prevention programs, we have chronic disease self-management programs, chronic disease support, family caregiver support. If they need that, you can click on that. If the person has memory loss and dementia and they're having issues around behavior or need more respite support, you can click on any of these that apply, and the AAA will contact that person and offer those supports. So this is an easy way where you don't have to remember, what are all the things I should be remembering? You could refer a person directly to their area agency on aging. And not a lot of people know about this. So I just want to remind you about that if it's there, and if you wanted to try it out and see how that works for you. So if you go to the next slide, you could also let families know directly about that website themselves. If you want them to know, here is this resource about resources in your area, you can get these free rack cards to have in your office, or you could have a stack on your desk to give people when you're meeting them. These are free. You can go into this Google form link, or again, there is this QR code. You could just take a picture right now and have this little order form, and you could get these rack cards free for your office. If you go to the next slide, you guys all know about the Dementia Roadmap. I'm not going to preach to you about that. What I do want to tell you is we have just been finishing up a Russian translation. So we have it in English, we have it in Spanish, and we will soon have it in Russian. You can order your bulk copies of this with this website here, this My Print. It goes to our warehouse and those get sent out. You do pay shipping and handling, which we weren't doing in the early years, but it just got untenable for us to be managing all of that mailing. So I hope that still works for you guys. It's still a pretty good deal for the product that you get for just the cost of shipping and handling. If you go to the next slide, again, you guys know about this, just to bring it to the top of your mind. We still have the Dementia Legal Planning Toolkit, which you can get to online. And you could get them in print version from Washington Law Help. I just found a whole bunch of them in my office that we're moving. And so I found them sort of buried in a closet. And, so if any of you want a box of those, sort of email me, and I can, you have to send me your shipping address and I could send some out to you. We also have the Dementia Legal Planning Project. And again, bringing it top of mind, what we have done, we got money from the state legislature, and we have contracted with Washington Pro Bono Council. And what the Pro Bono Council does is they link up with 16 different volunteer lawyer programs. Through this program, these folks have gotten training in issues around the Dementia Legal Planning Toolkit and dementia in general, so that they have sort of added to their book of business. Some of these free legal clinics and estate clinics, they now are more aware of dementia and the needs that we have for people to be completing their powers of attorney out, ideally before they get dementia. So this is a free program. Anybody who is 60 over or dementia of any age can access this pro bono legal support. So to be clear, though, the support that they provide is help in completing powers of attorney for finances, powers of attorney for healthcare directives, and dementia directive. So they can't do any complex, legal stuff, say around guardianship or more, but they can spend whatever it takes, an hour or hour or two, to complete those forms. So I think that's something to keep in mind. If you have people who are on the edge, they just haven't completed their forms, they just need somebody to help them, right? You can refer them by phone or to this website. You can literally go to this website and see a little more information about it. You could download this flyer, have it in your office to give to people. We'd really like to increase uptake. What they're doing is they're going out and they're doing a lot of legal planning sort of workshops and clinics locally, and they're taking this information with them. But if you guys have, places where you think we could share more of this information, let us know. Again, it's the Washington Pro Bono Council who's doing that work. And then this slide, if you go to the next slide, I'm not sure how much you guys knew about this. Tatiana Sadak and the School of Nursing group worked with some other folks on the Dementia Action Collaborative in developing this partnering with your healthcare provider training, which is really for families to help them be better partners in working with healthcare providers around getting the care that people need. To teaching them a little bit around communication, things that they could be tracking and then bringing to you when they have their visits. So I don't know, if some of you haven't seen this, you might want to just go in and look at it and see if there's some tools in there that would be useful to you, because they could be tools that you could give them to be doing some tracking and help with communication. It's free, online, self-paced. So it's a pretty easy accessed kind of thing. And then, of course, we have our Dementia Safety Info Kit, which remains online with the Action Collaborative, which can be useful to help families if you want to pass them some information along. And then on the next slide, this is something that people haven't been, this one. I want to talk a little bit about behaviors, because this is something that did come up in our listening sessions around the need for more support around behaviors. And making some more education more clear to people about where it is. And again, I know you guys have had several sessions on, non-pharmacological approaches to behaviors. But what I wanted to point out is when we were working on this beyond diagnosis tool that I mentioned earlier for providers, we did have a little section in there on what could providers talk about in a session where you don't have to get in the weeds about a behavior, but you could provide some really basic sort of guidelines for families to sort of promote behavioral health. And again, I know that you sitting in this room likely know these already, but I just want to remind you that you're in a really influential position with families, and you could provide some reinforcement around behavioral health and helping families remember some of these really basic tenets. If they haven't learned this through some training or support group, there are some certain things that families really could be doing to help prevent or minimize some behavioral issues. I used to do a lot of consultation in residential care settings and in the home with families. And very often when you track back and you do a problem-solving approach around behaviors that are occurring, what you find is that sometimes it's due to some really basic things that the caregiver is doing. The caregiver is trying to rush the person to get out the door, rush the person to take a bath when they're, really nervous about taking a bath. They might have unrealistic expectations about what that person can cognitively do. So it can be really useful if you could even share some simple things around behaviors, like simple things. And I'm talking about routine. That routine is really important for a person with dementia, and at different stages more important than others, right? And so talking about building a routine for the person, sticking with the routine, controlling the level of stimulation, encouraging tasks and activities that match their cognitive abilities. Sometimes we need to simplify things. We don't say, go get dressed. We give them a choice of 2 things to wear. You limit the choices, you simplify things. And also, one of the things families really need to know is thinking of behaviors as a form of communication and thinking that all behavior has meaning. Those things are really powerful in terms of understanding behaviors. And, I think families need to recognize that there's usually some feeling underneath a behavior, and some behaviors literally emerge out of frustration, fear, sadness, and sometimes underlying those emotions and responding to the person in that moment and validating their feelings can really help diffuse a situation. So, these are simple things, but they're hard for families to do and they need support with them. So if we can encourage families to reach out to the Alzheimer's Association. They have a lot of online trainings, support groups. Reach out to a family caregiver support program if they're having behavioral issues, because there are supports to help families with this. You don't need to solve all of them, but you can help direct them and guide them to somebody who can. So if you go to the next slide, I just want to share, here is one simple tool you might be able to use around behaviors. We had taken this and borrowed this from the state of California. They had developed these caregiver tip sheets done in very simplified language. The first one is called the IDEA strategy, which is similar to the DICE program, if you're familiar with it. It's literally a problem-solving approach. How do you teach a family how to look at the behavior, identify it, think about what might be contributing to it, and adjust things so that you might be able to minimize that behavior from happening. So I think this IDEA strategy is one that you guys could use in your office, just very briefly handing it to a family or guiding them or coaching them. And then there are 18 different topics on common challenges, like challenges with bathing. What if the person's getting lost? Hallucinations, paranoia, resistance to care, sundowning. And it offers some really basic, simple tips. It's not going to solve all the problems, but it is something that can help families start to think about the fact that they can have an impact on behaviors. So I'd encourage you to take a look at that. They're available in English, Spanish, Japanese, and Chinese. So we're trying to take advantage of whatever's out there in different languages, because there's not a lot. So just wanted to share that. And then lastly, this is a resource. I use this in my case manager program training. It is just literally a cheat sheet, because sometimes we get stuck and we think there is really no way to help this family. They're frustrated, they're, overwhelmed, but there are a variety of ways to help people at every stage along the way. And when you see a little CG in parentheses here, that is a service targeted at caregivers versus targeted at the person who's living with dementia. I think sometimes we sort of think, we can't solve all the problems, but sometimes offering, say, our home and errand service, which we have through our family caregiver support programs, that can take a burden off the family caregiver. And then some of the other things might not feel as stressful. Or having the family caregiver go to powerful tools for caregiving can teach them self-care skills, and then they don't get quite as frustrated or upset about some of the behavioral issues that are happening. So I would encourage us to think broadly in terms of how do we support the whole person and the whole family, the family caregiver and the person with dementia. And at any stage, again, always recommending the Alzheimer's Association, area agencies on aging to help with this. You guys don't have to solve it all, but that there are resources out there that have, that are available to help people. And then lastly, I just want to circle back to the plan and just give you sort of a highlight about what's going to be coming next. Our great health and medical subcommittee led by Chris Rhodes, and many of you in this group had helped develop these recommendations that we wanted to work on. At our first Dementia Action Collaborative meeting this year in September, we got to meet in person, and the whole DAC weighed in on what was the most important things to be working on in each subcommittee. So you'll see that one of the things that rose to the top for health and medical was to identify and promote strategies to improve brain health. So that's one of the things we'll be working across sectors to do. And then the other thing that rose to the top was to expand outreach around Project Echo Dementia. And the other thing was we did just get the BOLD grant. The Washington State Department of Health received the BOLD grant, which gives money to departments of health to really build out the public health infrastructure around dementia. And so through that work, we're going to be promoting Project Echo Dementia and Cognition for Primary Care that's under Dr. Gaster's leadership. So I think the BOLD grant is going to help us to do this one, that is to expand Project Echo. And then another thing that rose to the top, and I think this might be a little ambitious, but it's really interesting, is to host a collaborative Alzheimer's and Dementia Research Summit, highlighting some of this latest research. Not quite sure yet when that's going to happen, but it is sort of this vision you might start hearing more about. And then one of the other things that we're going to be working on really soon is this healthcare provider survey. We didn't get to do this during the planning process, so it's a real sort of fundamental thing that we want to do right at the outset to help guide the work that we're going to be doing going forward over the next 5 years. So if we can go to the next slide, Sam, what you'll see is the Dementia Action Collaborative Provider Survey. What we really want to assess the needs of healthcare providers. How is it going now? What do people need? What do providers need to do a good job? How can we help you as providers in this sort of space? So the target audience with this survey will be primary care, allied health, specialists, and we have a doctoral of nursing student helping us with this, so she has a pretty limited timeline because she's working on her capstone project. So we have this window from January 8th to February 3rd when the survey is going to go out. And Jamie is supporting this student, so you're going to be hearing more from Jamie and or the student whose name is Emily. And we're going to be asking for your guys' assistance with dissemination, because we know you guys are all champions in your own settings and you may have some contacts. So we're here today to sort of ask for some help. If you have a listserv or a network, how we can get this survey out to providers beyond you, because you guys know this stuff. We want to get this out to providers who are not as engaged as you. So we're requesting that you could help by emailing Jamie and letting her know of any ideas or lists that you might have, because it's hard to get healthcare providers to them and then have them have the time to complete a survey. So again, just asking for your help, and we have a link to remind you to email Jamie if you have ideas. So lastly, I'm at my last slide, and I just really want to say that I had mentioned earlier this Appendix C, and our staff team was really excited about this section. So I don't think you're going to be quite as excited as us, but I want you to be excited because this is where we want to pull in new people to align with our goals and strategies. So, what we fully recognize is the Dementia Action Collaborative or state agencies, none of us can do this alone, right? No matter where any of us are sitting, we just need this big, bold response to dementia. So what we created this Appendix C. So we went through all of the goals and we started thinking through what are some simple actions that people in our partnerships could take. So whether you're an individual, whether you're in an aging network, long-term care, or healthcare, what could you do now to help this effort? So we created what is Appendix C, suggested actions for partners. And again, we can put the link in here. This is also on our Dementia Action Collaborative website. And it offers some suggestions, things people can do now. So it offers resources for brain health, resources for countering ageism, resources to create age-friendly smart phrases, for example, into an electronic health record system. Or here's the link if you're interested in cognition in primary care, go here. If you're interested in Project Echo, go here. So it's really simple stuff, but it's stuff that we would really, we need to get out beyond us. So I would just encourage you all to take a look at this and think, is there something you can do? Add stuff to your website? Is there stuff you can share within your own health system? And do you have partners beyond you and your system who need to know about this? Because again, this is sort of a big effort. We need to sort of start getting out beyond our group who is passionate and informed and, get the information out beyond. So with that, I am at my last slide and just reminding you that we have a website where all this stuff is put together, hopefully easy. Again, there's a little QR code, which Jamie helped me develop. She's very savvy with her technology. So you could put that on your website because I know you want to remember all this information. And I, again, just thank you all who've been involved with this process. And, if you have questions, I'm happy to entertain them or welcome emails anytime that you guys have questions.
Lynn, I just want to thank you for not just this wonderful didactic and all these great resources, but just your indefatigable enthusiasm, energy, and leadership for all this. For those of you who don't know, Lynne is both the glue that keeps this process together and the engine that drives it. So really has been such an honor to get to partner with you to do this great stuff. We do have 5 or so minutes. If we any questions or comments or feedback about the tools that you've used,
or about this survey. If you have any questions about how we can get this survey out, I know Jamie would appreciate that. The student, she has limited time. So if you guys have ideas about either the tools or the survey, that would be helpful.
I think I missed. Could you tell me more about what the survey is, the objective and the questions on it?
Well, yeah, I can tell you a little bit. The objective is really to sort of gauge what are the challenges and the needs of healthcare providers around dementia care. So it will ask some repeated questions that we asked 7 years ago about how comfortable are people in using screening tools, for example. How comfortable are you in making a diagnosis? What are the barriers to making a diagnosis? What are you using as resources? How would you like to get training and information? So it's those kind of things. It's literally what we could use to help us reach health providers, because we always bump up against time, competing demands. How do we get this information? How do we get people's attention to dementia when, they might be in a practice where they don't have a lot of older people, but they're going to have more older people, right? So we're trying to figure out how do we get to the people, who aren't passionate about it already. So it's really information to help us do that stuff. Does that help?
any other questions or comments from the community before I give Karen Hayes a chance to ask? All right, Karen, go for it.
Yeah, so thank you so much for all of this. It's really exciting as someone who's was a caregiver for 8 years, to see all this pulled together so invitingly and rationally and user-friendly and so forth. So one comment I'll make, which I'm just noticing, and we might start noticing it more as my generation ages, on the end of the baby boomers. And even with my mother-in-law in her 90s and when my mother is her 80s, there's this funny, maybe it's American culture, they see themselves as forever young. Like, oh, I see these dementia things and everybody has gray hair and they look old and I'm not that. And it's like, you're actually older than the people in this picture, Mom. But so there's this funny thing. And I think with more recognition of the different dementias and perhaps them getting diagnosed earlier, kind of in late middle age and so forth, that to start thinking about some of the pictures being representative of maybe middle-aged people, because breaking through that denial of aging, the reality, my husband was a early onset dementia, and he didn't want to do anything with all these old people. And so it was a real barrier for me to try to sort of get him into programs and support groups and so forth. That is harder to get them in when they're more advanced dementia because some paranoia and they don't want to leave home and da da da. So anyway, yeah, that's just a comment that I'll make to keep in mind for the future. Just age awareness in the photographs.
Yeah, I think that's a great point. And one of the interesting things that we're working on right now, and it is within this plan, 2 things we're already starting to work on is a movement towards an age-friendly state and a multi-sector plan for aging. Because one of the things that we have found over the years is we've been trying to do dementia work, but we don't have a strong, when we look at our healthcare provider workforce, our long-term supports and services workforce, there is just some basic lack of knowledge around aging in general, healthy aging, and geriatrics, right? So getting people familiar, and this part of that is this called reframing aging. If you're interested in that, you could just Google reframing aging, and it's a whole movement about how we message about aging. So Karen, it's exactly sort of what you're talking about. Is
and someone who's been gray since they were 30 years old.
Well, exactly.
I've been reframing this my whole life, but it's the comments like, your hair is old, but your face is young. I mean, it's just so weird.
Yeah.
Now that I'm in my 60s, had a husband with dementia, a lot of my friends now are caregivers for people with dementia. It's not a geriatric milieu anymore.
Right. Yeah. And I just think we need to be talking about aging. In order to talk about healthy aging, we just need, we're all aging from the moment we're born, and we have to start recognizing that what we do as youth and things accumulate over time. And that's where the social determinants of health are coming into play, is that we have many communities who have poor access to healthcare, poor access to a lot of things over their lifespan. And, all of us accumulate these health conditions over time. We just need to take this wider, broader, longer span look at things and see how it all fits together. So you might be excited to hear about some of those as they emerge, Karen. I don't know what area you're in, but you'll be hearing about Age Friendly and our multi-sector plan for aging probably within the next year or two as things evolve. So thank you for saying that. That's a really good point.
Lynne, I really appreciate the kind of heightened focus on brain health and optimizing brain health across the lifespan that is pervasive in this report, or in this version of the state plan. So I think that helps kind of tie those generations together too.
Yeah, absolutely. Thanks, Chris.
All right. I'm mindful that it's 1 o'clock, and I want to make sure we have plenty of time to talk about Julie's fantastic case. Any other last minute didactic questions going once?
Yeah, just, I try to say this succinctly. I really appreciate your the way that you presented all these really complicated case resources that are out there that are just a lot of people don't know about. It's hard to do. When I try to do it, I feel like I've got some tips. Some of the things that I don't know, I think this is a Washington state issue. It's an issue with a lot of states, is that when we think about like promoting equitable access and well-being for patients and caregivers, like in our state, probably in a lot of states, one of the issues is, for instance, our COPES program, which is that main program that provides care to people in home and when they need residential care for folks that are low, moderate income. The assessment for that, to benefit for that, is not dementia friendly at all. It's based on like needing help with activities of daily living. And as we know, people with Alzheimer's, even with pretty significant care needs, sometimes score really artificially low on their needs on that. And so sort of thinking about like, are there ways to advocate with the state to kind of look at that, the way that they do that assessment, so that we can help our folks that we work with to access the services that would really help, promote those like wellness, well-being for both the patient and their families, addressing equity issues, and not just specific to dementia, but that the whole like low reimbursement rate for DSHS, especially around residential care, is just a huge barrier for our family members.
Yeah, I agree with you. I was just in a meeting yesterday where there was some, talk about looking at the way, care is done. And I'm not saying it's going to change right away, but, we have had those discussions, and I will keep your name on file when those discussions start happening. I would love to pull, to have somebody like you inform that process. Like, this is what you see from your end. So thank you for saying that, Karen. And if I see opportunities to influence that, I will let you know and call upon you. But thanks.
Great. I'd love to be involved in that. Thank you.
All right. Julie, are you feeling ready to transition to your case?
Yes, ready to jump in. And I have Susan, the social worker here at Prestige, with me.
Wonderful. Welcome.
Yes.
And for those who weren't here last time, do you want to do maybe just like a 5-minute overview? I know it's hard with the case with this kind of complexity, but
Right. I have a second shot at getting a summary and bit more succinct. So I'm Julie Holgado, I'm a nurse practitioner. I round at Richland Rehabilitation Center here in Tri-Cities. I'm out of a Catholic Senior Health Clinic. And so the patient I saw was admitted to the rehabilitation center on early November following a pelvic fracture, and she was treated at that time for UTI. She had told me a story about falling down the stairs. I had just received update today that I was actually outside of a donut shop here called Spudnex. So that was a different story. But she has a past medical history of frontotemporal dementia that was diagnosed previously by a neurologist based on there's some imaging we'll see on a different slide, she does have a seizure disorder, history of syncope, vertigo, history of anxiety, but not treated, history of asthma, uncomplicated. She has been living at home with a male caregiver since 2021. 2 marriages and currently widowed, 1 daughter who lives on the East Coast, not involved, never smoker, daily wine drinker, and she, notes here, I will cut off, retired seamstress, and she moved from the East Coast about like 20 years ago and has been by herself pretty much that time. So on initial presentation, her caregiver reported frustration that she has been having worsening dementia at home prior to this fall. She had a lot of resistance to therapy initially, a lot of barriers based on behaviors. And from the very start, there were some red flags that we might have trouble with discharge planning. For instance, she reported that she no longer trusted her caregiver and that there were some weird comments made during our initial conversation that made me concerned about this caregiver. So I presented her as a case on sort of problematic when it came to future discharge planning, and wanted further discussion, especially to support Susan's conversations with patient, family, caregiver on decision making and future planning. So this is kind of a copy and paste from her neurology notes from June of 2023, so fairly recent, that she was really dependent for all her instrumental activities, daily living, and she was no longer driving, forgetful, really unable to provide a detailed history. And so that also weighed in with my impression that she needs a lot of caregiver assistance for her daily living, even if she conversationally is pretty conversational. Next slide is, I think next slide is about her imaging, and MRI was done in June last year. And there's the next slide will be her PET scan, I believe. Yeah, PET scan from 2009 was suggestive of early frontotemporal dementia. After our presentation last meeting, I think there was a suggestion to discuss whether she did have frontotemporal dementia or other cause such as, well, I'd like further discussion of that. And then we've got the MRI imaging. So this, she is on, so her home medication, Keppra, is managing her seizure disorder, and she's not on any memory medications. She was advised to cut down her wine consumption, but from her conversation, she was really just drinking her glass a day at home. Next slide is, this is still from the, oh, okay, this is from the 26th of, there were some statements that were concerning staff of possible suicide ideation and refusing therapy, refusing showers and belligerence. So kind of these behaviors, which sounds like from her daughter, were not inconsistent with her previous personality or the way she's been treating family members prior to this. Next slide. Okay, so the main questions were advice on discharge planning for the patient and recommendations on future planning for dementia care. And then also discussion on immediate safety and how to get her to participate with her team members at the skilled nursing facility. So the update since our last discussion of this case is that she does have a last therapy day of discharge on Monday. So she has medically remained stable, no concerns medically. Pain is improved, ambulating with walker over 400 feet. She is having regular bowel movements. She's eating. She is staying hydrated. Her participation has improved, where she has participated with therapy and she has been eating with other residents with cognition is stable, where she is alert, she's oriented to herself but not oriented today, and not cognizant of recent events, not remembering recent events or remote events. So short-term memory is still markedly impaired on examination, but she seems to be kind of in a cognitively stable state. With that being said, we're still in the situation where her medical decision-making, her decisions for herself are really questionable of how much good judgment she has. And her decision for Monday is to go home with this caregiver. So that is, that's a plan for Monday. After our conversation and the last case presentation, APS was contacted. I believe you contacted APS.
Yes, APS was contacted.
But I was triggered by, though, there was an event on the 2nd where the caregiver took her from the
Yes.
facility.
Yes, the caregiver attempted to take her to the bank. He is the fiduciary, so he's on all of her bank accounts, credit cards, debit cards, everything is in his name. But, so with the calling APS because she didn't want to go with him, but he wanted her to go and he was trying to convince her to get to the bank. The Richland Police Department said that, while she's here, he cannot come on the premise. So, and then Adult Protective Services were also contacted in the same regard. But she is telling me she still wants to go home with him because, and the word that she's using is he's necessary. Like, but I've told her that she could get another caregiver. She doesn't have to have him. She'd go to assisted living. But she says, no, it's her house and she wants to go home and she wants him to be the caregiver.
Yeah, I think what's an interesting side note is I
Yeah.
saw on the progress note that there's that APS said that they were aware of this caregiver.
Yes, yes. And
So-
so has the Richland Police. They said that they've been aware of him. But there's nothing, it's kind of on the fence. There's nothing criminal that they can point their finger to.
It's just a lot of
Yeah.
red flags and
So,
so a lot of concern about
Yeah.
like where how best to plan for Monday for her safety,
right.
how to on the medical side, she is in well health. She's high fall risk. She's had one fall while she's here. She's forgetful. She forgets to use her walker, things like that.
Yeah.
Pain though is not a huge issue. If she was in just in an environment where she has reasonable monitoring and care, I would not be concerned about her discharging.
Okay.
So that really is about safety for her social situation and for future planning. There's a question from Sylvia.
Yeah, so I think one question that I had, I might have missed it, but have we evaluated her ability to make decisions in terms, at least medically, you know, I think that's the only thing we can do quickly without a psychologist. But just like, can she reason through these choices? Because if she tells me, I don't want this person. And then for a couple of days later, she says, well, I want to go home with him because he's necessary. Can she reason through the pros and the cons of going home? And can she maintain a straight up story? Because if she can't, it's harder to follow her judgment on this, I would say.
Yeah, I think that was my question from the start, was just her daughter is somewhat estranged, lives on the East Coast and hasn't seen her in 20 years. However, her daughter has been given paperwork that she's her healthcare power of attorney. That was recent, within like 2 years.
Yes, very recent.
Very recently assigned her daughter as healthcare power of attorney. The one thing is, because of the estrangement, her daughter's not flying here to convince her for a better plan or not getting involved that way. So I would say, back to your question, is she is exhibiting poor judgment and exhibiting a very poor memory in terms of being able to retain enough knowledge to make good judgment decisions. And yet I don't know if we can use that information to empower like a healthcare power of attorney to make a different judgment, or make some sort of change other than, yeah, that'd be, that's been my question from the start is, at what point can a social worker say to a healthcare power of attorney, you know, your mom is not able to make this decision for her? Or, I mean, she's in that gray area where she, you know, so back to cognitive testing, we usually get a slum score, we usually get some cognitive testing, but because of poor participation, we did not get a cognitive test done on her. So I really don't have a score to say where she's at cognitively, other than her orientation is poor, her memory is poor, functional status based on even the neurologist's evaluation in June has been poor. Yeah. So
I mean, if I were in your boots, I don't think you could be faulted for invoking power of attorney where her daughter is not like a court appointed one, where her daughter is not really actively making that decision. If she can make that decision, then great, but it's also kind of iffy if she doesn't know she's not there, she doesn't know the ins and out of the situation, you know. But I don't think somebody could fault you for saying and putting down in writing, well, she hasn't displayed good judgment when it comes to medical decisions. And so how can I trust what she's saying? At the same time, there is the potential risk that there is an abuse from a caregiver, but that I don't think we have enough proof of, you know. And so that's the trickiest part. But from my perspective, I would actually invoke extra help in making a decision like this, especially if there is a concern that she's going to be admitted to the hospital, or she has falls, or this person may not be doing things the right way. The other thing that could be considered, and I don't know how insurance works in her situation, is just giving her a course of home health physical therapy with a home health nurse or aide, which can kind of keep an eye on things, knowing the background. Those are the things I would think of if I had to kind of weigh in.
yeah, that's what we'll just generally set up as a home health referral. And the local home health, they get out pretty quickly, and they are pretty good at calling if there's concerns. So that is a good point, that there's that extra layer of protection for the temporary course. I think what I am glad for is, especially since we were doing this as case presentation, especially since early on we had these conversations, that there has been a lot of communication between like Susan and the daughter, and the care conference had included the daughter and the niece. And was the caregiver in the?
Yes, the caregiver was there, and the daughter by phone. Yeah.
So at least there's more awareness. Even the caregiver on initial presentation to the facility was expressing his awareness that her dementia is worsening. So if anything, we have increased awareness. So it's just a frustrating situation where I hate to feel like we are discharging her with the expectation that if this fails, then we'll have it. What's hard with her memory being so poor is I just don't think she's ever, no matter what happens, I don't think she's going to come to a point where she's going to give up her home or give up her independence. At some point, it will have to be, someone will have to come and decide that for her, is what my feeling is. Which it doesn't appear to be this admission. Unless someone absolutely argues it, then we could argue it. Oh, okay, Dr. Gistar.
Just to acknowledge what an impossible situation this is, that there's no easy, like, aha, here's the thing that you should do, because everything, any path you take is going to feel like uncomfortable or not quite right. And it's just super, super hard. And so I guess, the things that I would really come down to are like, in some ways, like she's saying that she wants to go home, and and that's like, and it's, living in one's home is an incredibly high priority for people. So the odds are so high that if the person who she was 10 years ago could look upon herself now, she'd be like, I want to stay in my home. Don't send me to an adult family home. I want to stay living where I am. And so if it's likely, in terms of like from an autonomy perspective, that both what she's saying now and what she probably would have said 10 years ago is, highest priority for me is to stay in my home. And if there's no signs that she is like receiving poor care in her home, then it's hard to say, nope, we don't think that that's the best thing for her. And so if she's getting like what seems like pretty adequate care, which is like not easy to provide by this caregiver, then that's like probably like, I would just like validate that your sort of like plan, as sort of like shaky as it feels, is like probably the best sort of option that there is. And then there is this kind of like hanging sort of like feeling of discomfort of, could there be like financial abuse happening? So is there a possibility that the caregiver is somehow like taking advantage of her financially? And that's like just going to be incredibly hard to sort of like adjudicate and tell. And so I think one possible solution in talking to the daughter is, just to share that slight concern with the daughter of the potential for financial abuse, and raising the question of, could the daughter sort of be given some kind of like sort of joint oversight of her finances in addition to the caregiver, sort of as like a protective measure for her. And it doesn't require her flying here. It doesn't require the patient moving to the East Coast, but that there could be something where there's at least another set of eyes who has like maybe some sort of sense of sort of responsibility to sort of look out for the best interests of the person to be involved in managing her finances. But oh my gosh, this is so hard.
No, I mean, I really appreciate both points. The point that, honoring her autonomy is still really important, and that it has been working for her at home. Really, the fall was not in the home, and she was not showing signs of neglect. And so we really don't have any true clear-cut reason for her not to go home, except that these red flags. And the financial part of it is a great suggestion, that now that there has been enough of these red flags and enough communication, that it seems reasonable to suggest that.
Yeah. And the other thing is, you're mentioning home health services. I've requested a social worker to go in to just kind of assess the situation, because, we can't, or not knowing what the home situation is looking like. And then they can kind of see if there's other red flags that show up.
I'd say one really benefit from presenting the case the previous week was, there was the thought of, as a medical provider, of whether I throw in some medications in the mix here. And I'd say that after talk with the case manager, presenting the case, and law of deep thought, I did not add any psychoactive medications. And I'd say that in general, she has stabilized, and she's not exhibiting such distress or need for any such intervention. So I'm kind of grateful for an ability to talk it out and kind of figure it out that way too. Which
and
yeah.
Julie, I'm curious, is the APS investigation still ongoing?
Yes, it is.
Okay, so that's, you have that kind of set of eyes also, right? Where I'm wondering, Karen Clay, is that what you were gonna ask also, or? Oh, you're muted.
Yeah, I mean, I think you're right that it's great that APS already has is aware of this and could follow up a little bit. I guess I wonder, do we know more what she's saying she doesn't trust about him? Can she articulate what that is?
She has it to me and she won't go into any detail.
Yeah, let's see. It's very vague. The niece, I talked to the niece on the phone and the patient said, I don't like the caregiver. And then he said, I know, we'll, something like that. She just placated. Just like, I know you don't like the caregiver. And then the patient herself said, well, he's never made advances towards me. He's so young, he's half my age. So she made some sort of comments like that, that's just his age, that kind of, and that he's a man, that made her feel like there's something that could go wrong with it. I'd say his times that he was here, he's been attentive towards her.
Right.
If anything, maybe a little overly control, maybe just a touch overly
Controlling a little bit, yeah.
just a touch, but nothing worrisome except the little too involved at times.
Yeah.
Yeah, is he a romantic partner?
No.
Yeah.
No, not at all. Okay.
Absolutely.
And is he actually legal power of attorney for finances?
No, he is fiduciary, so he does not have decision-making power, but he helps her, write her checks, make sure the bills are paid and all that.
That was my question. Who's the financial POA?
It's the daughter who's back east.
Okay.
both
So she
financial
has both healthcare and
and
finances.
Yes.
Okay.
yes.
Which
Okay,
some
good.
haven't
So-
been involved with both of those. I imagine it's just a
Yeah,
matter of
she needs to step up and get involved, I think.
Yeah.
And you talk to her, does she sound caring and interested or?
Yes, yes and no. If she was
You
here
pause.
locally, yeah, if she was here locally, she said there was more she could do, but she said being on the East Coast, she said there's not a whole lot she could do. And she doesn't have a whole lot of financial means to come out here to help, so.
no, here's a question, because I feel like empowering the daughter would be helpful.
Yeah,
It's almost if she's financial power of attorney and she doesn't feel like she has the means to come out and visit her mom, isn't it something she could use her mom's funds to come and help her? I mean,
Yeah.
yeah,
But I wonder about the control this guy holds over the funds. So,
yeah,
the red flags with this person, and if somebody is being abusive and manipulative, when you start bringing other people in, they're going to start getting really, because their control depends on isolating her
yep,
from family and from other people who are trying to mess with his plan, just ascribing malevolent motives to his attachment to this woman. And so, doing some of these things is also like poking the bear a little bit and watching what he does. And it really concerns me that his name is on her accounts and everything. I mean, it's one thing to
yeah,
have maybe a very low level credit card with his name so he can buy her stuff at Rite Aid or whatever, but for his name to be on her accounts and not the daughter's, that just seems really strange to me.
yeah,
And
that was a
daughter
big
with
red flag.
financial power of attorney can turn that around.
Yeah,
that's true.
Yeah. And I do think that the daughter should really be the one that's talking to the adult protective services person about like, hey, I'm powerless to really do these things to follow up on this. What are our other options, so that they could maybe help with guardianship, if that's sort of deemed to be appropriate for that. I also, my kind of second questioning with thinking about like, is the gentleman kind of open to kind of dementia care tips? Like, is this partly a case of him not understanding ways to connect with somebody that's having some cognitive difficulties, and maybe some of those resources that Lynne talked about today could be helpful for him.
Yeah, I think he actually, his care of her and like the
Yeah.
way he approaches her is very sensitive. If it's anything, it sounds like she has a past of cutting people off and just turning on people without any provocations, from what I heard from the daughter.
yeah,
So her saying that she doesn't like him, to me sounded like it's more of a pattern that she has with people.
right.
Got it. Yeah. I love that you're also doing that referral for the home health that's going to be able to be going in there with their eyes open and letting them know that there's those concerns in the open adult protective services case. It's a great plan.
And that's another test of this guy. If home health comes in and starts expressing some concerns and he pushes them out, or we don't need them, you know, that's a red flag. Opposed to him maybe being receptive to like, oh yeah, great, more people here to help, that's great, versus we don't want other people in the house because now they're starting to have influence on her, or they're going to turn her from me, you know. It's
Will the daughter be like a contact person listed for home health? Like, if there is
Yes,
a
she
problem?
is actually the first emergency contact because she has the POA for healthcare and finances, and then he's listed, the caregiver is listed second.
Great.
So, yeah.
And I think what I got from the daughter is that she just feels powerless. And so like the more like concrete,
Yeah.
you know, tasks and things that she can, I mean, financial you can do from
Yeah,
across the
sure.
state. But yeah, what I heard from her is that, well, I live across the state, so what can I do? Frustration, I've been down this road with her before. I've wanted her to be in assisted living and she didn't take me up on it, and you know, it's never going to get better. That kind of just feeling helpless.
Yeah.
And so if anything, just the mindset, oh, there are some actual concrete things you can do might be enough to get her just a little more engaged.
Right. Yeah.
Well, we will be thinking about you on Monday.
Thank you.
I think it was really
Yeah,
helpful.
no, this
Thank
has
you.
been very helpful. Yeah.
Thank you. And it's been, you know, to Barack's point, I mean, I think it resonates with all of us just how challenging these things are, including, you know, the things that people bring with them to dementia, personality characteristics and other, you know, psychological problems and ways of interacting. And boy, those get compounded.
yeah, and ruptured past relationships. Yeah.
All right, well, it is 1:30. The link for the 1-minute survey is in the chat. I'm gonna share my screens one last time because I wanna make sure you're aware that on Friday, December 8th, our own Dr. Nancy Eisenberg will be talking about women's brain health. And we will kind of give you an idea of what next calendar year looks like for our sessions. Have a great Thanksgiving or other holiday event between now and then, and we'll see you back on the 8th.